Hi, everybody. Good afternoon or good morning, depending on where you are. And welcome. I'm Amy Hajari-Case. I'm a Senior Medical Advisor for the Pulmonary Fibrosis Foundation, and this is the next installment of our disease education webinar series. I'm very excited today about this topic. It's something that people have lots of questions about, and that is familial pulmonary fibrosis. We'll be talking all about that today with our guest speakers. So I will go ahead and make a couple of introductions. We have 3 folks speaking with us today, and then they're going to kind of take it from there. Just one second here. So Dr. Lee is, where did my notes go? How are you guys? Really? I have my notes on another screen, and it's giving me lots of trouble today. All right. Man, the technical difficulties. It's also getting a little hot in here. Believe it or not, this never happens. All right, I may have to make you introduce yourselves because I am not getting anywhere with this mess. But I do have Dr. Lee with me. She is an associate professor and director of the ILD program at the University of Colorado. She is also one of my fellow senior medical advisors at the PFF. We are also joined by, I'm very excited, Janet Talbert, who is a board certified genetic counselor. She has been doing genetic counseling in pulmonary medicine for 20 years. She's currently, she was formerly in Denver, we were just talking about that, and is now at the Vanderbilt University Medical Center in the Division of Medical Genetics and Genomics. And she is there building a pulmonary genetics clinic to serve the patients and families with inherited pulmonary disorders. And our final speaker for today will be Rachel Warren. She's the clinical research program manager. She's been working with Dr. Lee and Dr. David Schwartz at the University of Colorado on their pulmonary fibrosis research studies for 5 years. And she's going to talk with us today about the APPLE study, as she's the primary point of contact for that. So welcome to all of you. I'm going to do just a little bit of housekeeping before I turn this over to Dr. Lee. Just to remind everyone, if you haven't been to one of our webinars previously, that the information we have here is just for informational and educational purposes, and that if there are any personal questions about your health, they should be directed to your own personal physician. And then finally, if you will take a look at your control panel on the GoToWebinar platform, usually it's to the right of your screen. If you have any technical difficulties or anything there that you need to ask about, you can drop us a chat message in the chat box, and we'll try to help address those for you. One level up from that, there's a little drop-down menu for handouts where you can find the slides in PDF form, and you can download those for your own use. And then 2 notches up from that is the questions drop down, and we'll be taking some questions at the end of the session. So if some come up during the course of the talks today, we would love for you to drop those there. We'll try to get to as many of those as we can during the course of the talk. So I am going to now turn this over to Dr. Joyce Lee to get us started. Thank you for being here.
Great, thank you, Amy. It is a pleasure to be here to speak with you about familial pulmonary fibrosis. I'm going to get us started in talking about what is FPF, and then Janet will talk to us about genetic testing, and then Rachel will end our discussion on how to get involved in research, and followed by questions. Next slide, please. Next. So pulmonary fibrosis, just to get everybody on the same page, is scarring and or inflammation of the lung tissue. And as many of you know, there are several different types of pulmonary fibrosis, and a particular disease called idiopathic pulmonary fibrosis, or IPF, is one of the more common forms of pulmonary fibrosis. And this is largely where most of the genetic data come from, but I will say there's been increasing investigation and understanding of the role of genetics in other forms of pulmonary fibrosis, such as chronic hypersensitivity pneumonitis and rheumatoid arthritis-associated interstitial lung disease. Next slide. So what makes a case familial? So a case is considered familial if there is a diagnosis of pulmonary fibrosis when at least 2 relatives within the same family have that condition. And there are other clinical features that increase our suspicion for the presence of familial pulmonary fibrosis. And those include obviously a history of pulmonary fibrosis for any reason in 1 or more family members, the age of pulmonary fibrosis onset within a family. So those that are younger increase our suspicion for a familial case of pulmonary fibrosis, or this concept of genetic anticipation, which means that subsequent generations develop the disease at an earlier age compared to the prior generation. The presence of lung cancer and pulmonary fibrosis within a family also increases our suspicion for the presence of FPF. And then, of course, there are what we call extrapulmonary manifestations of disease. So signs or symptoms outside of the lungs that make us suspicious for familial pulmonary fibrosis. This includes bone marrow problems, conditions like aplastic anemia or myelodysplastic syndrome, or other less severe forms of anemia where you can detect that on a blood test. Other extrapulmonary manifestations include unexplained liver cirrhosis or portal hypertension, so high blood pressure within the liver blood pressure system, and then premature graying of the hair. So really, developing white hair by the 3rd or 4th decade of life are all features that are not diagnostic for, but make us suspicious for familial pulmonary fibrosis. Next slide, please. So what do we know about the genetics in IPF? So approximately 20 to 30% of people with idiopathic pulmonary fibrosis will have a family history of pulmonary fibrosis. And several genes have been discovered in these families who have IPF. They include common variants such as the MUC5B variant, but it also includes rare variants, things that you may be familiar with called telomerase variants and surfactant protein genes. Notably, these variants that have been observed in familial pulmonary fibrosis have also been observed in patients who don't have a family history of pulmonary fibrosis but have IPF. And so what this tells us is that genetics alone don't account for disease development. So genetics will predispose an individual to develop the disease, so it puts you at an increased risk for getting the disease. But there are likely other factors that develop to the actual development of the disease. So whether it's aging, smoking, infection, or other environmental insults. Next slide, please. The other things that we know about genetics in IPF is that certain genetic variants are associated with different clinical outcomes. And so I've already shared with you that certain forms of familial pulmonary fibrosis can have other medical conditions, so bone marrow issues, cancer, but other variants can also be associated with how the disease progresses over time. And also certain variants can be associated with different clinical features, so age at diagnosis, the graying feature, or even different CT scan patterns that we observe when we image patients who have pulmonary fibrosis. And more recently, we've also identified that you can have different types of pulmonary fibrosis within families. So it's not always IPF that is the disease manifestation, even within the same family. Next slide, please. I really liked this figure in this review article that was published in Chest in 2021 that kind of helps frame different diseases and the risk of having familial pulmonary fibrosis. So in the left-hand circle, this is all cases of familial pulmonary fibrosis, and you can see the proportion that is contributed by these different diseases. So 2/3 are due to idiopathic pulmonary fibrosis, 20% due to unclassifiable forms of interstitial lung disease, about 10 to 12% with hypersensitivity pneumonitis, and about 8% related to an underlying connective tissue disease, ILD. You could also look at it in terms of the diagnosis. So you can see idiopathic pulmonary fibrosis in the red circle. Of all the cases of idiopathic pulmonary fibrosis, familial accounts for 25%, where sporadic accounts for 75%. The next circle is those for hypersensitivity pneumonitis, and you can see that the proportion of familial hypersensitivity pneumonitis is about 15%, and then unclassifiable, that proportion is about 15% as well, and then for connective tissue disease-related ILD, the familial component comprises about 5%. Next slide. So often a question that comes up is who should get screened for pulmonary fibrosis with a CT scan? And at this point, there are really no set clinical practice guidelines on when and how to screen for pulmonary fibrosis in patients who are at risk because of their family history of pulmonary fibrosis. That being said, I think early symptoms should be taken very seriously, symptoms of dry cough or shortness of breath. And anyone at risk should remove or avoid any environmental exposures. So smoking cessation if they smoke, avoidance of dust, chemicals, and fumes, and then avoidance of other factors associated with pulmonary fibrosis, such as lung toxic medications and organic antigens like birds and mold. And there's a group that's coming together to try and inform this question a little bit more clearly so that we're all on the same page in terms of screening. But research will really help us guide this in the future. Next slide. And so with that, I'm going to hand it off to Janet.
Thank you, Joyce. And thank you to the Pulmonary Fibrosis Foundation and Dr. Lee and Rachel for allowing me to be part of this webinar today. I've probably spoken to many on this webinar before, so welcome back. Good to see everyone. Next slide. So the way, kind of folding into what Dr. Lee mentioned as far as how I think about pulmonary fibrosis and heredity versus familial versus sporadic, we really kind of have this pie chart of the majority of cases are not familial. They may still have a contribution of genetics, whether it's common variants or rare variants. And any disease that clusters in a family, but we don't know the genetic cause, because families share genes as well as environment, we call that familial. And when we can actually identify a genetic variant or mutation, the new lingo in genetics is variant. So because there's a spectrum of variation in the human genome. So when we can identify a genetic mutation or variant that is causative or contributing heavily to the development in the personal or family history, then we call that inherited forms or heredity. Genetics is going to play a role in a little bit, but like Dr. Lee said, it's not the main contributing factor for all cases of pulmonary fibrosis. Next slide. So just to back up a little and give a small primer on genetics, we all start out as one cell with our complete genome that we inherited half of our genes from our mother, half of our genes from our father. And those are packaged on structures called chromosomes. And those chromosomes are really just tightly wound coils of DNA. And along those coils of DNA is our entire genetic code in every cell. And our DNA is made up of 4 letters, A, T, G, C. And while the field of genetics has moved from prenatal pediatrics into now, later onset disorders like pulmonary fibrosis and cancer, we're learning that sometimes these genetic variation that can cause disease can come down to just 1 letter sometimes. And our genes mainly code for proteins in the body that carry out functions. Next slide. So I like to liken our genes to books in a library. We have over 20,000 genes as humans. We have 2 copies roughly of every gene. And we basically build our library from our parents' library. And if you think about a library having sections, we know that there are several books already or genes that have been discovered on pulmonary fibrosis. So when we do genetic testing, what we do is we go to that section of the library, we pull down those books, both copies, and we basically look through for typos in that book. And even typos, just like in our written language, can have harmless typos like 2, 2, and 2, there, and there. So does our DNA, and that's what kind of makes us unique. So not every mutation or change or variation in our DNA means that it causes a disease, but there are rules, or maybe through studies we've discovered certain typos can actually contribute or cause the disease itself, and that's what we're looking for when we do genetic testing. Next slide. So I just wanted to kind of break down a rare versus a common variant. Again, these are mutations, but now they're variations. Rare ones are ones you think about more, like a genetic syndrome in a family or something that's strongly inherited. It's rare because if you have a disease that is especially so harmful that it might cause death, you don't want that in your entire population. So it has to be a rare disease in the first place, and it has to have genetics with mutations or variants that are even more rare in the population. And these kind of follow those classic genetic conditions that cause dominant inheritance, recessive or X-linked. And you've heard about some of these, like cystic fibrosis or Marfan syndrome or Huntington's disease. And typically these rare variants that are harmful are usually always in the diagnosed individuals, but not in your healthy average person walking around. And it's thought that they have a stronger, if not direct, cause for the disease. And what else is unique about rare variants is they can be anywhere in the gene. So they can be usually in the coding regions of the gene, because those are the parts that make the proteins, but they can even be private to each family. So it's not just one location. Now, if you contrast that with the common variants, and these are kind of the new kids on the block because of our technology has allowed us to find these at a much more frequent and powerful testing when we do research, they can also be inherited, but they're in a greater proportion of the population. And they're usually found in both diagnosed patients as well as healthy controls. So for instance, they could be in 20% of the population, and that 20% of the population will never develop the disease. So they're more thought of as associated with a risk that's contributing, and they have a smaller effect in direct causation of the disease. And they're always in the same location, usually not even in coding regions of the gene. But what's unique about these is they can be used for therapeutic targets. And a lot of companies, just a little word of caution, like 23andMe or Ancestry tests might return results that say that you have a variant that's been linked to pulmonary fibrosis. It's usually going to be one of these common variants, and it's not going to carry the weight that a rare variant would. So it's always helpful to talk with a genetics professional if you have concerns. Next slide. So this is just a smattering of what genes that we've discovered so far. All genes are designated by an acronym, and this is complicated because the disease itself is complicated and the genetics are even more complicated, and we're still learning. But on this graph, on the y-axis, you have how likely you are to get pulmonary fibrosis based on a mutation or rare variant. So you can see it's higher, but on the bottom, it's very rare for a person to carry these. All the genes in that top left bubble are ones that we can currently clinically test for, and they only represent about 30% of people with familial pulmonary fibrosis. Now, there's some caveats there and there's some nuances, but in a person with familial pulmonary fibrosis, we would expect them to have a 30% chance to have a mutate or a rare variant that is causative in that family. So we still have 70% of families that we don't have an answer for yet, and that's why we continue to do our research. Now, if you go along the x-axis, you see that the more common a variant gets, the lower contribution it has to direct disease development. And that's where you're going to see a lot of those, like 23andMe tests come out with some kind of statement about pulmonary fibrosis. And I just want to say that pulmonary fibrosis is also tracking with other late onset disorders that have a familial, hereditary, and sporadic component, like cancer. I could put breast cancer, colon cancer up at the top there, and we're going to have a similar slide, just different genes. Next slide. So when it comes to the question of should I get genetic testing, you can already see it's pretty complicated, and not everybody has the background knowledge. Not every physician has the background knowledge of knowing who to test, when to test. And it hasn't been routine in general for pulmonary fibrosis because, you know, we've not had this many genes in the past. The cost has been pretty astronomical. All of those things are changing. We've found several genes now. The cost has come way down, and sometimes it's covered by insurance. It just depends on person to person. So because of this and the demand from patients and family members wanting more genetic testing, the Pulmonary Fibrosis Foundation worked with a working group, and I was on it, and we developed kind of some soft guidelines on when to consider genetic testing, kind of those clinical suspicions like Dr. Lee had mentioned. But in genetics, in the genetics field, we always want to test the right test for the right patient. So we want to make sure we're targeting those genes that fit with the clinical presentation. We want to know what we're going to do with that information. A lot of times this is going to change the medical management, and because some of these genes have extrapulmonary features like bone marrow issues or liver disease, that might make your doctor look more at those conditions or look out for things that can affect that. And the test results themselves can be complex and sometimes takes a genetics professional to kind of work through those results because it's not always black and white. Again, it's 30% that we get a positive hit or a known gene mutation. Sometimes we get back inconclusive results that we don't really understand because everybody has genetic variation. And then, of course, if we do find a genetic mutation or variant, that can be a very powerful tool for relatives in the family, because then going back to that library analogy, we know what book it's in, what page it's on, what word it's in, what letter it is. So it becomes very powerful. Next slide. So with this PFS statement, we basically outlined when to consider genetic testing. Who are we going to test that's going to give us the highest yield to get an answer back? And, you know, just even right off the bat, anybody with familial pulmonary fibrosis, we have a 30% hit rate if they're willing or wanting to do it. I think it's, we thought it was advantageous to offer genetic testing, or in patients with FPF or even sporadic cases that have some of those extra pulmonary features that Dr. Lee mentioned, the liver or the bone marrow failure. Targeted testing in family members when there's a known variant that's harmful or pathogenic or disease causing. There are some rare inherited syndromes that I haven't even mentioned because they're known causes of pulmonary fibrosis, but they're usually early onset, like Hermansky-Pudlak syndrome or neurofibromatosis, that really are their own ball of wax or disease unto themselves. So they usually get picked up, and we rarely see them in our clinics for interstitial lung disease. And typically, because of that anticipation, sometimes we can see younger age of onset of pulmonary fibrosis, and that's always a clue. And some of the genes do track with that. And Dr. Lee had mentioned lung cancer. There are certain types of lung cancer that have been seen to move through a family with pulmonary fibrosis. Next slide. So instances where genetic testing wouldn't be helpful or may send us down a rabbit hole is just blanket testing patients with pulmonary fibrosis with no family history or no extrapulmonary manifestations related to those known genes, or just randomly testing unaffected family members when you don't have a starting point in a person with the diagnosis, because a negative result isn't a true negative unless you have something to compare that to. Common variants, until they have some kind of clinical utility, which we already see that in other disorders like cancer or ocular disease or like breast cancer, we can use those common variants and determine treatment options or maybe a therapeutic target. So common variants don't give, because of their low causation rate with disease, they don't have a what we call in the field positive predictive value, meaning we can't give you any kind of percentage that you would develop pulmonary fibrosis off of a common variant. We know like odds ratios only. And we shied away from saying that it would be a tool for lung transplantation. I know some centers are using other types of genetic testing in lung transplantation, but not like DNA testing, testing for those known genes. But it may come to pass that we use genetic testing as part of a lung transplantation workup to help the patients on the other side of that transplant and what kinds of treatments they get based on their genetics. Next slide. And other considerations that some people don't think about, there are state and federal laws that protect a person from having a genetic test result used against them that would impact their health insurance or their employer. But it doesn't usually pertain to life insurance or disability, and this mainly impacts people without the diagnosis. The diagnosis itself is, considered a pre-existing condition. A genetic test result, if you don't have the diagnosis, it's just a predisposition. It's not pre-existing because it's not 100% chance you'll develop it, even with a genetic mutation. But there are laws for health insurance and employment, and unless your state has some caveat law for life insurance, I don't know every state law, I don't want to. But the other alternatives is not to do genetic testing, maybe do DNA banking. Sometimes there's hesitation from family members. They don't want to know about a gene in their family. And due to that low yield, we only have 30% approximately accounted for. Sometimes the testing just kind of puts us right back where we are, but we can rule things out. So that's a little bit of a flavor of what I do. Now I think I'll hand it off to Rachel. Oh, sorry, I had one more slide. So in summary, you always in genetics want to test the most informative people, and those are usually with the diagnosis. And then it can become a good tool for relatives or in clinical decision making. Therapeutic targets are in the future for the common variants especially. It's a little bit harder when there's mutations along a whole gene and different families. And genetic testing, because it's not been routine, it has been hard to integrate into clinical practice, but the goal is to have it integrated as a multidisciplinary approach, just like you get your CT or your breathing test and you pathology and then your pulmonologist. So now I think I'm finished. Thank you.
Hi, everyone. My name is Rachel Warren, and I work with Dr. Lee and Dr. Schwartz at the University of Colorado. I'm just going to talk a little bit today about some of the research opportunities that we have available to familial pulmonary fibrosis families here at the University of Colorado. Next slide, please. So if you are a patient with familial pulmonary fibrosis, we have our Genetics of Pulmonary Fibrosis study. It is a registry study that Dr. Schwartz started about 25 years ago and is still currently running to this day. You are eligible for the study if you come from a family with 2 or more cases of pulmonary fibrosis, with at least 1 case being IPF. It's an adult-only study, so ages 18 plus. And the procedures, we try to make it as easy as possible for folks that already have the disease. It's just 2 steps. It's a paperwork packet that includes an informed consent form, a release of information form, and a health questionnaire. And then the second step is a one-time blood draw. I'll mention that no travel to Denver is required. We do everything over the phone and through the mail, and you can complete your study procedures locally. Next slide, please. The other study that I'm going to spend most of my time talking about today is a research opportunity for your family members that do not have pulmonary fibrosis. And that study is the APPLE study. It stands for Advancing Prevention of Pulmonary Fibrosis. And we are sponsored by the Pulmonary Fibrosis Foundation and the NIH for this study. Next slide, please. So the goal of the APPLE study is to enroll 1,000 individuals that we consider to be at risk from families with 2 or more cases of pulmonary fibrosis. And what we'd like to do is study this population to determine who may have early pulmonary fibrosis and who doesn't, further define the genetic profile, understand the environment, and follow these folks over time to determine who progresses and who doesn't, which will help us identify other risk factors for disease development and progression. Next slide, please. So who can participate in the APPLE study? So if you come from a family with 2 or more cases of pulmonary fibrosis with at least 1 case of IPF, that's the first thing. And you also have to have not been diagnosed with interstitial lung disease by a physician. And our age range is between 40 and 75. And if you're willing to complete the study questionnaires and procedures. Again, with this study, you do not need to live near Denver to participate, and multiple family members are welcome to participate as well. Next slide, please. So the study protocol, so we're looking for families with pulmonary fibrosis history, and we're looking again for the unaffected family members between the ages of 40 and 75 within those families. And we're looking for 1,000 participants for this study. And we're hoping that folks will go on this journey with us for 4 years and do yearly questionnaires, biosample collection, including blood and others. And we're also doing a pulmonary screening for each participant that includes a high-resolution CT scan of your chest, as well as pulmonary function testing. Next slide, please. So our recruitment so far, we're looking for 1,000 individuals in our cohort. We have over 500 to date. We've scheduled over 300 CT scans and over 250 PFTs. And as you can see from this little map here, not all of our participants are in Colorado. We have a spattering across the country, and we have set up a CT scan and PFT in all 50 states at this point. Next slide, please. So I mentioned that it's a 4-year study. How does follow-up work for these folks? So all participants will be contacted every 12 months with a follow-up questionnaire. And this is to assess any changes to any potential environmental risk factors or any new clinically significant outcomes, like if you've been diagnosed with an interstitial lung disease or an IIP, vital status, medication changes, etc. The other thing that we'll mention related to follow-up is that 2 years after initial consenting to the study, about 450 of our subjects will be asked to repeat the questionnaires, the biological sampling, and the high-resolution CT scan and PFT. And again, this is to look at progression over time. Next slide, please. So if you're ready to get started, or if you have any questions or are interested in getting your family enrolled in research, your next step is to contact me. That is my direct office line as well as my email address. I've also put Dr. Joyce Lee's information on this slide as well. You feel free to contact her as well if you have questions about the APPLE study or the genetics of pulmonary fibrosis study I mentioned earlier. But thank you for inviting me to speak today.
Okay, we're gonna come back. All 4 of us will be back on for some questions. Rachel, one of our first questions was, I think you just answered, but I'm going to put that contact information right back on the screen just to give everybody an opportunity to get that down, your email and phone number. And to be clear, this is for both the familial pulmonary fibrosis study and the APPLE study. That's correct, Rachel?
Yes, that's correct. I'm the point of contact for both.
Wonderful. So everybody out there, there's a lot of you on today. I know there's a lot of interest that could be candidates, think you might be, aren't sure, would like to participate. Go ahead and reach out. There's your contact information right there. So I will just start. We've got a lot of great questions. Just as a reminder, If you have questions for our panel here today, then go to your control panel, hit the drop down arrow on the questions tab, and you can submit your questions there. So one question, and Rachel, actually this is relevant for you, but I think Dr. Lee or Janet both could weigh in here. How do you define family in terms of familial? Is it first degree relatives? Do cousins come into that? How does that look? And maybe that's study related, but also more in the clinical realm.
I can start, and then maybe Rachel can follow up with, and Dr. Lee can weigh in. But you know, from a genetics perspective, we've always defined it as 2 or more first degree, but we include second degree. I think when you get out third degree, like cousins or great aunts, uncles, it starts to, you share less genes. But I think at this point, for a research standpoint, we might take any and all. But technically, it's usually first and second degree, meaning siblings, parents, children are first degree. Second degree can be aunts, uncles, grandparents. But when third degree, it's more like cousins and great aunts and uncles. Dr. Lee, do you have more for that?
Yeah, I agree for sure. And I think that for the research purposes, it's really first degree relatives. So if you're, if you're the patient with pulmonary fibrosis, your children can participate if they're above the age of 40. Siblings that are not older than the age of 75 can participate. And then if you have nieces and nephews, we really want that link to, a sibling to help us create that connection. So it's for the purposes of the study, first degree relatives. But I think when we think about more broadly familial pulmonary fibrosis, I agree completely with Janet, it's first and second degree relatives.
Great, thank you. So a good question here, and I'll start with Janet on this one if that's okay. So the genes that are playing a role in creating risk or causing the pulmonary fibrosis in a family, and a family with known pulmonary fibrosis, does that risk decrease from one generation to the next, or does it ever go away, I guess is one question.
So genes don't necessarily skip generations. A disease can. So genes either get passed down or they don't. And the genes that we've discovered so far typically follow a dominant inheritance pattern with what we call reduced penetrance, meaning it's not always guaranteed you'll get it, even if you carry the genetic variant or mutation. So it's 50-50 whether a gene variant gets passed down to the next generation. And then if it doesn't get passed down, it stops and it won't get passed down further. If it does get passed down 50-50, then the next generation is at a higher risk, but they may not develop the disease due to reduced penetrance, but they can still pass it down to their children who can then become affected. So then it looks like it skips a generation, but the gene mutation is still being passed down 50-50. So I don't think it would only decrease if the genetic cause is not being passed down.
Gotcha. I think that was pretty clear. I'm going to clarify because we've had a few questions about this. So just to be clear, and you said this really well, you said the disease can skip a generation, but the gene, if it gets passed down, could still be passed down again. So just because the generation isn't affected by the disease, they may still pass on the gene that puts the person at risk. Did I say that correctly?
Yes, correct.
Awesome. Okay, let me ask another one. And Joyce, I'm going to ask this one of you first, and then Jan, if you want to weigh in on this as well. We actually had this come up earlier as a question, and I think some of the folks that were interested in this may be here today, but asking about telomere length and the relationship between that and development of pulmonary fibrosis. I know that you didn't talk a whole lot about this, but I know I saw some telomere-related genes on your list there. Can those telomere shortening syndromes, those can be inherited, and how is that then related to pulmonary fibrosis? If somebody has short telomeres, for example, is that because of their pulmonary fibrosis, or is that just a risk factor for it? Can you talk a little bit about that first, Dr. Lee, and then Janet?
Yeah, so I think the issue of telomere lengths is an important one, and one that we did not address specifically in this the talk. But telomere lengths, for those that don't know, are the caps of your chromosome, and so it protects that the genetic material between these within the chromosome. And these telomere lengths can shorten over time, and naturally they get short as we age, and other factors can cause telomere shortening, lack of exercise, alcohol, other things can affect the lengths of the telomere over time. And what's been discovered in IPF is that many patients have short telomere lengths. Some are due to a rare variant in telomerase, so telomere gene mutations that lead to shortening of the telomere length. But we've also learned that patients who don't have familial pulmonary fibrosis or who don't carry these rare variants in telomerase can also have short telomere lengths. And there's a lot of research that's being done on what is the role of short telomere lengths in the biology of idiopathic pulmonary fibrosis. And I think there's a lot of work that supports that short telomere lengths in the lung are bad, and that it leads or promotes the process of pulmonary fibrosis when the telomere lengths are short. Clinically, we've also observed that short telomere lengths can be associated with worse survival in patients that really do have short telomere lengths. And then also those that undergo transplantation can have complications related to some of the immune suppressant medications as a result of these short telomere lengths. So having a short telomere length does not equate to having familial pulmonary fibrosis or having a disease, a variant causing disease in that particular individual. But having short telomere lengths is clinically important for the patient who has the disease, and would love to hear Janet's perspective on this as well.
Yeah, no, great recap, if you get my joke. Yeah, so more, so my understanding has always been that most patients with interstitial lung disease have shorter telomeres than average. And the lower they get, like in percentiles, the more likely they have a increased risk for a genetic variant, but it doesn't always mean you can find one. So they're considered a risk factor for probably other conditions too, like bone marrow failure and other things that we see, because short telomere, there's even something called a short telomere syndrome, where you can have bone marrow issues, pulmonary fibrosis is lumped in there. So short telomeres can also be inherited from a parent as structural from those chromosomes that already have it. So that can create that anticipation, and the disease timing, age of onset, and even clinical features could be seen at an earlier age. But typically patients with IPF and the familial, and especially those with known variants in one of the telomere genes, have the shortest telomeres. Amy, could you go to that slide where I had all the genes listed? Because I did mean to.
Yeah, give me a sec. Let's see if I can find it. Go directly.
This is the one with the X and Y axis.
Yep, give me, let's see. I didn't quite go. I think this is forward.
And just while you find that, And when I mention lung transplantation, it's more looking at the telomere length that can help inform if that patient needs to be treated differently post-transplant, more so than testing for the known genes. So in that rare variant bubble, the ones in black are all telomere related genes. It's kind of like a chain gang. They all work together. And TERT is usually the most common one. And it's so important that it even shows up as a common variant too. So we know that TERT is one of the bigger usual suspects. The ones in red are more the surfactant and more rare, but if we're bound to find a mutation, it's usually going to be in the black genes there because they're all in the telomerase pathway, and typically patients will have shorter than average, usually below the 50th percentile. And the closer you get to the first percentile, the more likely you might find an actual mutation or variant, but the lack of finding one does not rule out a short telomere syndrome or risk.
That's great. I think that's really helpful. And I always get intimidated by this slide, but I think once you really start to think about it and have it explained, I think I've now heard it explained by you maybe like 10 times, and I think I'm finally getting my head around it. So some more questions that we have, and keep these coming. They're really, really great. What would you recommend? Maybe, Janet, this is a good one for you. If a patient in a family with familial pulmonary fibrosis has genetic testing done and does not come back with any known associated genes.
Okay, is that patient affected? They have the diagnosis? Right. And that's going to happen 70% of the time. We're not going to get an answer from testing the genes directly. I mean, telomere length could be looked at as well and to see, but my guess is they're going to usually be at the 10th percentile. That's pretty average. But again, telomere length can't diagnose or tell you prediction or anything like that. And more than likely, they're going to have a short one. So we've only found 30% of families. So we still have more genes to find. There's over 20,000, and these kind of come in every couple of years. So that patient can be retested. But an important point is if a patient with FPF does not have any findings from the genetic testing, there's no reason to test anyone else in the family until something is found.
That's a
so
very
at that point, it doesn't rule out a hereditary cause. It rules out the genes that are currently known. That's all it does.
And Janet, aren't the genetic panels slightly different depending on where you go and what they're testing for?
Yes. So that's where it also helps to have someone in the genetics field that's savvy to know what lab, the right test for the right patient. Not all labs are equal. They don't all offer the same testing. They may not have these genes and this one has those genes. Very rarely do we find one lab that has everything we want.
That's a really good point too. And Janet, just to go back, when you said retest, is that because you feel like additional genes will be added to some of these panels over time? More and more?
It already has happened. It's already happened because TERT and TERC were discovered in 2007, and then we didn't find any more until like 2015. So we went back and would retest patients in clinics sometimes and find a mutation.
That's a great point. All right, I have a question for Rachel. If an interested person, assuming they have familial pulmonary fibrosis and are a patient with pulmonary fibrosis, is in a clinical trial of let's say a novel therapy, would they be eligible for the genetics of pulmonary fibrosis study?
That's a great question. Yes, absolutely. We're a registry study. We don't do anything with any novel therapies or any new drug trials. It's just paperwork and a one-time blood draw. So that being said, the reverse is also true. Participating in our study does not exclude a person with disease from participating in any other clinical trial. So you can do both.
That's great. And since we have had that question, I am going to go back to the contact information in case anybody still hasn't gotten that down. So if you are currently in a clinical trial, you still could participate in this registry. And if you are participating in the registry, decide to do that now, it does not preclude you in the future from participating in other projects as well. And is that true, Rachel, for other registries like the PFF Community Registry, for example?
I'll have to defer to folks that work for the PFF on that one. I'm not a part of that registry, but I would assume so. Joyce?
Yes, absolutely. They can participate in as many as they want, for sure. I do want to say, though, as Janet mentioned, that it takes time to discover these variants associated with disease. And we're still, we only have 1/3 of the variants identified, even amongst people who have a known family history of pulmonary fibrosis. And it's research like this and similar studies that really help us keep chipping away at the genetic understanding of these conditions. And with patients who participate and family members who participate, we will start to shift that number from 30, 40, and hopefully to 100% of the genes that cause pulmonary fibrosis eventually. But it does, require participation by patients and their family members to help us do that.
That's a great point. I will use that to lead into another question, and then maybe Joyce, I'll ask you to do a little bit of sort of prognosticating and forecasting. So if you have if you are a patient with familial pulmonary fibrosis, and maybe there's a sibling obviously in the same family with pulmonary fibrosis as well, would you predict that they would have the same response to approved medications for pulmonary fibrosis? And then as a second part to that, sort of follow up to that question, do you see that, maybe some of these things that we're learning about genetics, beyond helping understand mechanisms, might at some point in the future help us to understand how people respond to medications, the ones we currently have and the ones that are going to be developed?
Those are excellent questions. And I would say with the 2 approved therapies for patients who have idiopathic pulmonary fibrosis, today we have no reason to believe that the efficacy of these medications is different depending on the genetic profile of the individual. The trials that led to the FDA approval of these therapies included patients with sporadic and familial pulmonary fibrosis, as long as they had the diagnosis of IPF. And as of right now, I've not seen any data that tells us if certain genetic variants predict responsiveness to treatment for the currently approved therapies. That being said, not everybody obviously responds to the therapy as they did in the clinical trial. And so we do know that there's a heterogeneity or differences in terms of treatment effect. And whether or not those are genetically oriented, we don't know. And I hope that our future studies really delve into the genetic risk profile of the patient and their responsiveness to treatment in the future. There's actually another study going on right now. It's the first pharmacogenomic study in patients who have idiopathic pulmonary fibrosis, another one that the PFF is heavily involved in, which is called the Precision Study. So this was based on some secondary data analysis. So they looked back at the Panther trial, which was the original trial, or the trial that was looking at immunosuppression in patients with IPF, and they found that patients who were given this combination of therapy had increased harm. But in that study, there was a NAC-only arm, and a secondary data analysis suggested that those with a particular variant in TOLIP might have a differential response to NAC compared to placebo. And so now they are doing an NIH-funded study to enroll patients only with this variant in Followup and determine whether or not NAC is helpful in this particular patient population. So it's a very exciting study because it is the first genetic-based study to look at treatment response.
I'm glad you brought that one up. I have another question actually, and either Rachel or Joyce, I think this is a good, well, actually all of you could help with this one. If somebody is tested, has genetic testing, they're affected by pulmonary fibrosis, they have genetic testing, there is no mutation found. And I think this maybe goes in two different ways. If they are in the genetics of PF study, do you retest, or would you retest sometime in the future if new variants are found, discovered? And then also, if that testing is done via a commercial lab, for example, outside of a clinical trial, does that lab retest in the future if their panel changes? So that's two-part question. One more study related and one more outside of study.
So I'll say from a study perspective, the genetic testing that's done on research samples is not what is done when it's sent out to a lab. And so the lab-based tests are very specific mutations in certain genes. The way that we do research-related tests is very different. So we're casting a much broader net, and we're testing all sorts of different looking for different variants that we may or may not know the clinical significance for. And so the approach to the research testing is very different. And we can retest DNA in the future depending on technology and other advances in science that might help inform future testing. But that just relies on us having enough sample in the future to be able to do that. So I think from a research standpoint, it's a slightly different thing as opposed to, we're not just testing for those that are on these commercially available panels. I don't know, Janet, I don't know that Janet can probably answer the one related to the commercially available ones.
Right. So the commercially available ones, usually we call them panels. And so all those genes I had in that left upper bubble could be a panel, and they could test for those, say, in 2018 and look through all of those, and it's like that library book, and they come back and say, no, we didn't find anything. It would usually take another sample if there are new genes that weren't part of that panel to begin with. Now, they can always go back and reanalyze their data if there's a specific new variant they found within those genes, but typically it takes a new sample. The only test that you can reanalyze every so often is like a whole exome, where they're looking at all genes that are coding, like 5,000 genes or so that they can test for, but that's not usually recommended for pulmonary fibrosis. That's kind of overkill. So I would always recommend, because the technology just gets better and better, and things they couldn't find 5 years ago, they might find now. So retesting with a new sample at a commercial lab would most likely be warranted.
That's thank you for those answers. I think that's really helpful. We have so many questions here that are still left unanswered, but we are out of time for our session today. If your question pertains to either the familial PF study, genetics of PF study, or the Apple study, please take down the contact information for Rachel and Dr. Lee and reach out, even if you think that have questions about whether you might be a candidate. Just reach out and ask. In my experience with pulmonary with clinical trials, we want to have a wide net and have all those questions asked. I am going to close by thanking our sponsors for their support of our webinars today, and our wonderful panel who participated with us and gave us such valuable information. Thank you all for being here today, and I look forward to seeing you again at our next our next webinar next month. And have a great rest of your day. Thanks, you guys. Great to see you.
Thank you. Bye.
Bye.